Hi, my name is Mariana Camarillo, and today I'm going to be talking about Bordetella Pertussis. Introduction. Bordetella Pertussis is a small aerobic, non-motile, gram-negative Coccobacillus that is responsible for the disease pertussis, also known as whooping cough. The microorganism Bordetella pertussis colonizes the respiratory tract and secretes a variety of virulence factors. I'm going to mention all of this information in the last part of my presentation. Now, let's talk about transmission. Pertussis is an infection that is highly contagious and is spread via respiratory droplets, which are effectively aerosolized by the coughing. Higher incidence is in children below 1 year age group. Now the incidence is less due to the vaccinations. However, the cases of pertussis are increasing. The incidence is not compared to the 1940s, but we are still seeing cases. Let's talk about history. Pertussis was a devastating illness with a high infant mortality rate before the introduction of a whole cell vaccine in the United States in the late 1940s. Pertussis vaccination of children went to a dramatic decline in disease incidence from a peak of more than 250,000 reported cases in 1934 to 1,010 cases in 1976. Since that time, however, there has been an increase in reported cases in the United States. For example, in 2010, there were 27,550 reported cases in several states. In 2012, there were more than 41,000 cases. That means this disease is increasing because pertussis is under-recognized and under-diagnosed in adults. The incidence is higher. The cause for the rising incidence of pertussis is not fully understood. Possible explanations include genetic changes in the circulating strains of pertussis. In addition, a cellular pertussis vaccine might not be efficacious as the whole cell vaccine, which is no longer available in the United States. Adults also act as carriers because they already have the immunity. Obesity and pre-existing asthma have been associated with a higher likelihood of pertussis diagnosis. In adolescents and adults, infection may result in a cough and is occasionally associated with substantial morbidity. In children, and particularly infants, morbidity is more often substantial and the disease might be fatal. Now let's talk about signs and symptoms. We said that pertussis begins when bacteria inhaling aerosols attach to and multiply in ciliated epithelial cells. Pertussis then progresses to 4 stages. The incubation period for B. pertussis ranges from 1 to 3 weeks, but is most typically 7 to 10 days. This is in contrast to the shorter incubation period, 1 to 3 days, for non-specific viral upper respiratory infection, cough illness, such as the common cold. Catarrhal phase is characterized by signs and symptoms that resemble as a common cold. This phase lasts 1 to 2 weeks. The bacteria are most abundant in and patient is more infectious. Now let's talk about the paroxysmal phase. Begins as a ciliary action of the tracheal cells is impaired. The condition worsens as ciliated cells are expelled. To clear the accumulating mucus, the body initiates a series of deep coughs, each of which is followed by a characteristic whoop, caused by the intake of air through the congested trachea. Each day, a patient might experience a 40 to 50 coughing spells that often ends with a vomiting and exhaustion. Lasts 2 to 4 weeks. Coughing might be so severe that oxygen exchange is limited, such that the patient might turn blue or even die. Please listen to this whooping cough. You can hear that kid. He's coughing, and then at the same time, he's trying to vomit. Now let's talk about the convalescent phase. The number of bacteria present becomes quite small. The ciliated lining of the trachea grows back, and the severity and frequency of coughing diminish. This phase lasts 3 to 4 weeks. During this phase, secondary bacterial infections might lead to pneumonia, seizures, and encephalopathy. Now let's talk about diagnosis. The presence of a cough lasting more than 2 weeks is sufficient for clinical diagnosis. Even in the absence of other symptoms, the choice of diagnostic tests, culture polymerase chain reaction, which is called PCR, and serology depends upon the duration of cough. For patients with less than 2 weeks of cough in whom there is clinical concern for pertussis, sensitivity culture is performed and has the highest accuracy. For patients with 2 to 4 weeks of cough, culture and PCR are performed. The sensitivity of culture declines after the first 2 weeks, but PCR remains useful up to 4 weeks since it can detect non-viral organisms. For patients with more than 4 weeks of cough, only serology is useful. Serologic testing typically involves comparing levels of pertussis antibodies. Patients with discordant test results should be presumed to have pertussis. Specimens must be collected by swab or aspiration from the ciliated respiratory epithelium of the posterior nasopharynx where pertussis resides. When the nurse is collecting this specimen, the nurse should be covering her face with a face mask. Should be using goggles and gloves. Now let's talk about the treatment. In general, antibiotic therapy is warranted for patients whose duration of symptom is less than 2 weeks. It might also be appropriate for patients with persistent symptoms for up to 4 weeks. Macrolides are highly effective at eradicating Bordetella Pertussis from the nasopharynx. Azithromycin should be taken for 5 days, 500 milligrams the first day, then 250 milligrams from day 2 through 5. Second option is clarithromycin, 500 milligrams twice daily for 7 days. For adults who cannot tolerate a macrolide antibiotic, they can take trimethoprim sulfametazole, 1 double-strength tablet twice daily for 14 days. Is an acceptable alternative treatment. Let's talk about prevention. The DTP vaccine consists of the whole cell pertussis vaccine combined with diphtheria and tetanus toxoids. The whole cell pertussis vaccine is no longer available in the United States, but is still used in other countries. Adolescents aged 11 to 18 years should receive a single booster immunization with Tdap. Adults aged 19 to 64 years should receive a single booster administration with Tdap. In addition, adults aged 65 years and older who have not previously received Tdap should receive a single booster administration with Tdap. Other measures for the prevention and control of pertussis include isolation in home and hospital room of known or suspected cases and post-exposure prophylactic antibiotic therapy. Now let's talk about the virulence factors. So we have the bacterium attaches to certain lipids in the cytoplasmic membranes of tracheal cells via two adhesins, filamentous hemagglutinin and pertussis toxin. Filamentous hemagglutinin also binds to certain glycoproteins on the cytoplasmic membranes of neutrophils, initiating phagocytosis of the bacteria. Bordetella pertussis survives within phagocytes, in the process evading the immune system. Pertussis toxin causes infected cells to produce more receptors for filamentous hemagglutinin, leading to further bacterial attachment and phagocytosis. Now let's talk about the 4 Bordetella pertussis toxins. Pertussis toxin interferes with the ciliated epithelial cells metabolism, resulting in increased mucus production. Adenylate cyclase toxin increases mucus production and inhibits leukocyte movement, endocytosis, and killing. This function might provide protection for the bacterium early in an infection. Dermonecrotic toxin causes localized constriction and hemorrhage of blood vessels, resulting in cell death and tissue destruction. Tracheal cytosine, at low concentration, inhibits the movement of cilia and ciliated respiratory cells, and at high concentration causes the expulsion of the cells from the lining of the trachea. The information given in this PowerPoint was retrieved from microbiology textbook by Dr. Robert Baumann and from Up to Date. Please, in order to avoid this disease, prevention, get your vaccinations and get your kids vaccinated. Thank you.